Okay, good day, ladies and gentlemen. Welcome to the social media stage and to this session, which is called Critical Interventions in the ED. Before we start, we are going to take the questions after the session, so in the end. And what you have to do is, if you have a question, just raise your hand and I'm going to throw you this mic. And then you have to talk into this green box. Okay, so we are going to start with the first talk, which is an ophthalmology update. Our speaker is David Ng. He's from Toronto, Canada, so give a warm round of applause for David.
Thank you, everybody. Go ahead and load up our slides. So my name is David Ng, and I'm an emergency physician from Toronto. I'm also an assistant professor at the University of Toronto. And we're going to talk today very briefly about central retinal artery occlusion, or CRAO, as an acute stroke of the eye. So I'm just going to put this out there. I have no conflict of interest, financial or otherwise. If you want to change that situation for me, I'm totally open to it. You can let me know afterwards. In the next 15 minutes, we're going to refresh our knowledge of the clinical presentation and pathophysiology of CRAO. We're going to know the management. We're going to talk about current evidence for thrombolysis, and we're going to know how to do thrombolysis, because this is about a critical intervention in the emergency department. So, CRAO as an acute stroke of the eye, as you guys may recall, this is a situation where you have an acute event with painless monocular vision loss. And it's going to be quick, just like this, and it's going to be severe. When people get this, over 75% of patients, they're down to just counting fingers, right? They can't even see the big letter on the chart. And this is a bad disease. So when people get CRAO, only 10 to 20% of patients get functional vision back. Now, we're here to talk about this entity as something that's similar to stroke. And this has actually been around since 2021. The American Heart Association, the American Academy of Ophthalmology, and even here, the European Stroke Organization, they all recognize that CRAO is an entity with pathophysiology and management that is similar to cerebral ischemic stroke. So that's the way we should think about it. So I'm a simple person. This is the pathophysiology. The internal carotid is a highway. It goes to the brain. If you get an embolus or you get an obstruction there, you get a stroke. We all know what that's about. But there is one branch that comes off before it hits the brain, and that's the ophthalmic artery. And a sub-branch of that is the central retinal artery. Your embolus takes a diversion, a path in that direction, and then you get CRAO, and you get that sudden onset, severe, painless vision loss. Okay, I'm going to also talk about, this is actually a rare disease, okay? 2 out of 100,000 patient years, and this makes it challenging because it's hard to get good research for optimal management when you have a disease that actually presents relatively rare. So, what are your treatments? You may have read in textbooks, you may have heard in emergency medicine podcasts, hey, let's lower the IOP, treat it like glaucoma. Let's do a paracentesis, let's stick a needle in there and into the eye and draw it out and push it back and forth. We'll have them hyperventilate or ocular massage, and everything here is supposed to dislodge the clot. But I'm going to tell you right now, there's never been evidence for any of this. There's not a single society of ophthalmology that endorses any of these treatments, so you can forget them right now. We're never going to do these. You don't need to do these. No ophthalmologist recommends to do these. What we should do, though, is we should treat this like a stroke. We should treat this like TIA. And you folks are all experts at treating CR or treating stroke and TIAs. You guys know it's about getting the blood work, getting the ECG, getting neuroimaging, and then they need stroke follow-up. The other thing is once you get a stroke or TIA, of which CRAO is in the same subcategory, they're at a high risk of stroke in the near term. And that's why we put patients on antiplatelets. And the same goes for CRAO. You should put these patients on an antiplatelet. And the American Heart Association in May, just this year, 2026, have endorsed it is reasonable to put on a patient with CRAO on dual antiplatelet treatment. So you guys might have heard, you got a minor stroke or TIA, you're going to put on 21 days of Plavix plus aspirin. Well, do the same thing for CRAO. The one thing that is going to be different is you're also going to consult or refer for ophthalmology. So don't forget, these patients need to see an ophthalmologist because the ophthalmologist is the person who's going to confirm the diagnosis, and they have to follow up for complications like neovascularization in the eye. Okay, so we've talked about antiplatelet therapy, but we can't talk about stroke if we don't talk about thrombolysis. And is thrombolysis in play for acute stroke? So the evidence is actually kind of mixed, all right? So in summer of last year, so this is all pretty recent stuff, there was a very robust meta-analysis of non-randomized studies. They had, I think, like 700 patients in non-randomized, small, uncontrolled studies. And when they did this meta-analysis, they found, hey, you know what? We can get a recovery of up to 33% of patients with thrombolysis can get functional vision back versus 11% with standard treatment. And this thrombolysis would be in the form of either intraarterial or IV thrombolysis. However, we actually have some RCTs cooking even right now. The first RCT or randomized controlled trial reported in November of last year unfortunately showed no statistical difference. There was a trend that treatment would be better than no treatment, or thrombolysis would be better than standard treatment, but it did not reach statistical significance. A second trial was published in January of this year, and it showed no difference. So the RCTs are making it look like, you know what, maybe the robust effect of the meta-analysis is because of confounders or selection bias or publication bias. There is still one trial out, though, and that one is actually headquartered here in Germany, and it'll be the biggest of all the trials. So hopefully we'll have some more definitive clarity about what direction to do with thrombolysis. So the American Heart Association has sort of looked at all of this to date, and they said this was published May of this year. So again, up to date, super current. I'm giving it to you fresh within the last month. Although not yet proven effective, there is enough evidence in smaller studies to justify consideration of thrombolysis in selected cases. And practitioners should be aware of this option and how to pursue it. So when I look at this, to me it sounds like we're not at prime time yet with thrombolysis. It's not a standard of care, but in the right kind of patient, if you've got the right resources, is something that you can consider. So if we're going to do this, how do you do it? So here's my little textbook here, or one-pager on CRAO thrombolysis for dummies, okay? This is a lot like thrombolysis for acute stroke. Number one thing, time. So in the studies that have been done, we're looking at a time frame of 4.5 to 6 hours. If the patient arrives to you in under 4.5 hours, you can consider IV thrombolysis. If they are already past 4.5 and they're under 6, there may be a utility of intraarterial thrombolysis. Intraarterial thrombolysis, though, is a very specialized thing. It's going to be in the hands of some very experienced interventional neuroradiologists. Not all of us will have access to this. You're going to do a stat acute stroke thrombolysis protocol. So whatever you're already doing for acute stroke under 4.5 hours for thrombolysis is what you'll do for this. So like I said, the blood work, the ECG, the stat CT head. And the extra things that are different here is stat ophthalmology. Now, I don't know how many of us have access or how happy your ophthalmologist is going to be to come in the middle of the night stat to do this, but that's what's going to take. And what they're going to do is fundoscopy and something called OCT, optical coherence tomography, to nail this diagnosis, to confirm this diagnosis. And the other thing that needs to be done, and this is our job as emergency doctors, is to do a stat screen for giant cell arteritis, because that is in the differential for someone who suddenly loses monocular vision. And that might mean you want to order an ESR or a CRP, because we want to make sure we're not lysing someone who we could actually treat with steroids, and their vision will get better with steroids alone. So everything in medicine has a differential diagnosis. There's always some suspects in play. We're talking today about CRAO, but there are a bunch of other things. So giant cell arteritis I've talked about, CRVO, central retinal vein obstruction, vitreous hemorrhage, retinopathy like retinal hemorrhage or a retinal detachment, optic neuritis. Like, we don't want to lyse any of these people, and we don't want to subject them to the risk of intracranial hemorrhage from lysis. This is why you need stat ophthalmology, because they have to rule out all these other things. The giant cell arteritis, we do our part by screening. Like, hey, are you having a headache with this vision loss? Like, are you having jaw claudication or scalp tenderness? Is there a tender vessel on your head? If you do, I'm going to do an ESR CRP stat. If that thing comes back positive, hey, everybody, let's hold it. We're not thrombolizing this patient. So this is pretty rare. You know, when people present with CRAO, about 5% of them will be giant cell arteritis. So we can't forget it, but it would be a rare thing among rare things. So what does the ophthalmologist do? I'm not going to pretend like I can produce this image on fundoscopy, all right? But this is why we need them, and this is what their job is. You can see slide A here. This is a normal, this would be normal fundus. I barely even remember the word for fundus. And here is the macula, and here are some vessels. And here is an abnormal or CRAO fundus. So they have the cherry red macula, right? And then the whole retina is very pale because there's a blood clot there. There's no blood coming through, so it's all going to go very pale. So pale retina with a cherry red macula, for those who still study for their exams, remember that is the kind of thing that shows up on exams. All right, so the other thing the ophthalmologist will do is something called OCT, optical coherence tomography. And the reason why this is important is this finding that I'm showing you on the fundus, this is pathognomonic. This will clinch the diagnosis of CRAO. But when you have acute CRAO, like within the first 2-3 hours, 4 hours, sometimes it's so hyperacute they can't make this diagnosis because this finding won't be there yet. And with OCT, so this is a cross-sectional imaging of the retina, what they will pick up is hyperreflectivity in the layer of the retina. And so if you have hyperreflectivity in the layer of the retina, the ophthalmologist will tell you this is an acute CRAO, then you know you can progress or proceed onto thrombolysis. And so this is what the ophthalmologists do. Now, I put this slide up here because I don't know what the future will bring, and we know ophthalmology is a limited resource. And so in the future, we may have access more to fundoscopic cameras for photos in the emerge. That way we don't need the ophthalmologist to produce this image. You might have access to an OCT machine. Like, if the evidence becomes very robust that this is a helpful therapy, you may make this interpretation based on photographs from a machine and then make the call. So CRAO, let's come back. What are we going to do? What's it all about? Number one, you want to treat it as stroke, and you want to call ophthalmology, because ophthalmology is going to need to follow up these patients. Thrombolysis evidence, it's still evolving. Thrombolysis is an option to be aware of, although it's not a gold standard at present time for treatment. If you're going to do this, you've got to be fast because you got to get this done in 4.5 to 6 hours. And the be fast, you're going to need to get this done quickly. You're going to call stat ophthalmology, and while you're doing that, rule out giant cell arteritis. My last slide is about the future. I'll be back. And this is the revision trial, which I'm talking about. This is the German trial. And they are planning, right now, the RCTs to date that aren't very good. They're small. We're talking about 70 patients. This one is, they're planning for up to 200 to 400 patients, so 3.5 times the size. So we are hoping that this will be definitive, one way or the other. Is IV thrombolysis acutely helpful and effective treatment for CRAO? All right, thank you very much, everybody. I'm going to be back here at the end. If you guys have any questions, I'll be able to help answer questions there at the end.
Thank you very much, David. For those who join us later, we are going to take questions at the end of the whole session. Now, I saw that our second speaker is in the audience. So the next talk that you're going to hear is about the evidence for thoracotomy in ED. And we have the honor to have, and I hope I'm going to pronounce this correctly, Helio Penna Guimaraes, de São Paulo, Brazil.
Thank you so much. Okay, thank you so much. So it's a perfect pronunciation. Thank you so much. I come from Brazil. Sorry for some mistakes in my English. And we'll talk about the resistive thoracotomy. Unfortunately, in my city, it's a frequent procedure because you have some problems with violence in Brazil, Rio de Janeiro, and even in São Paulo, my city. So it's so frequent sometimes to need to do the thoracotomy in our department. So the burden of a thoracic trauma is 25 or 50% of incidence in penetrating or blunt thoracic injuries among all trauma presentations. And 50% of proportion of these cases involve a trauma induced by cardiac arrest. So this is the immediate indications of the thoracic procedure. Relieve the cardiac tamponade, the direct control of intrathoracic hemorrhage, the open cardiac massage, and the seeding aortic clamping. I don't know if probably you have here. Unfortunately, in Brazil, you don't have REBOA. So sometimes if you decide to clamp it, the aortic, is necessary to open the chest and clamp directly the aorta. And the contraindications is, the main contraindications is the absence of vital signs, hypo arriving, and of course it's a very traumatic brain injury, OTB. The mailing point in terms of thoracic resuscitation open is decide when you should open the thorax. I think this is the most important moment to the emergency doctor decide. So one of the signs that's important, receive patients according to the Lawrence physiological status classification, receive patients that is still signs of life. The signs of life is responsible pulse, spontaneous ventilation, presence of central pulse, spontaneous movement, and the presence of cardiac electrical activity. So according to the Lawrence physiological status classification, this is the first part of this picture, as the class 4, as the medial shock, the patient with systolic under 16 millimeters of mercury, and blood pressure until 19 millimeters mercury. This is some data about this. The last data is this reference, Brigeron. Brigeron, it's a famous trauma surgery in Brazil, and this data comes from Brazil. We have, according to Brigeron data, we have a 23% of survival in cases of stable wounds. And the gunshot wounds, that's very common in Brazil, we have 1.4 survival. And the blunt trauma, unfortunately, in Brazil is 100% of mortality. So the demographic advantages, we have a high survival younger demographic. It's common in Brazil. Most of our thoracic traumas is under 28 years, every age. And is less frequent transport by policy. In Brazil, there's a law that's not possible to transport victims of gunshot by the policy guys, because in the past some policy guys have was involved as a criminal scene. So now it's impossible to transport. It's necessary to waiting the emergency department, the emergency service to do this transportation. The neurologic reality is 1.5% of cases of trauma. Only 21 patients achieve survival and good neurological recovery in almost 1,400 cases in Brazil. This picture is, I think this picture is the most important to resume this presentation. When you should think about the thoracic resuscitation, where is the point? The strongly recommendation is when you have penetrating trauma and still signs of life when you receive your patient. This is the main point to decision, open the thorax and try to do the thoracotomy resuscitation. The best scenario is when you have a patient with blunt trauma and pulseless or no signs of no vital signs when you receive the patient in the emergency department. To recover the procedure, the incision, you should identify the anterolateral region of the chest and the fourth or the fifth left intercostal space. Make the incision from the sternum until extending to the axilla, and release the intercostal muscle and the parietal pleura, and careful spread to ribs using a refractor to avoid the fractures. The anatomical navigation, it's easy when you see directly, and of course if you do the first time it's not so easy, but when you became a frequent procedure in your department emergency, and when you train with simulation cases, you should identify the pericardial sac, the left phrenic nerve, the left lung and the pulmonary humulum, the diaphragm muscle, esophagus, and the descending aorta to posterior of the heart. Just to remember, to internal cardiac message require use the bimanual technician, and it's more effective than closed chest compression, of course, but it's difficult to assess in the first time. And as I told you before, in Brazil you don't have rebua, so sometimes if you decide to clamp the aorta in Brazil, it's necessary to open the chest, so you can use clamp as the same of rebua in these cases in Brazil. I don't know if you know this technician. It's a kind of off-label technician. It's an off-label innovation. It's not so innovation, but sometimes it's necessary to use in cases like in departments you don't have enough resources. I work in 2 emergency departments. One of them it's a private. We have all kind of resources, but the most important for me is the public. The public is in the famous university in Brazil, University of São Paulo. There is a huge emergency department in São Paulo. São Paulo is a huge and crazy city. Many cases of violence all the time, so sometimes you don't have resources enough. And this kind of situation, happened with us in the last 5 years at least 4 times. So sometimes you can use the follow catheter. It's a technician to insert the follow catheter direct in the penetration myocardium wound to track this point until receive the thoracic surgery, until get the cardiac surgery. So the balloon is inflated inside the cardiac chamber, and the gentle threshold to seize to defect inside out. And sometimes you can use the line of the follow to infusion blood or to infusion any other kind of fluids if you need a line, a first and large line to resuscitation of patient. So the global reality of rate in terms of survival is 7.8%. Blunt trauma requires strictures criteria because the intervention should occur in the signs of life and in the 15 minutes. It's a level 4 for evidence. And in terms of costs, you have 800 until 7,200, and the clinical management in terms of $1,004. So it's not so cheap procedure. So you should decide the current moment to indication. So emergency department should be disencouraged when there is no chance of survival, because there's a great cost associated with these patients with a profoundly low chance of survival. To finalize, this is a kind of algorithm to decide what is the point you should make your procedure. So the blood association of extrathoracic trauma, if you have patients with signs of life, CPR or CPR in ER, you should individualize according to the age, comorbidities, and the other left-right injuries. And if you don't have signs of life, the best choice is not to perform the thoracic, intrathoracic intervention. And if you have a penetration trauma, this is the most important decision. If you have a penetration trauma and receive your patient, there is still signs of life, you should decide in 5 minutes, no more than this, if you have performed the open chest intrathoracic intervention or no, and sometimes you can use the follow insertion. This is the references you present, and this is a small picture of my center in São Paulo. This is the public center. This is the Helio Hospital. It's a clinical hospital, belongs to the University of São Paulo. It's almost 2,000 beds, and the emergency department will receive more than 1,000 patients in a week, and most of them is a trauma patients, unfortunately. That is my contact by email and telephone. I would like to receive you. You open to receive you in São Paulo to know this department and to stay with us during a month, maybe, to know a kind of traumas you have. Thank you so much.
Thank you very much, Helio. Please stick around for the questions in the end. I assume that there are going to be some questions, quite a lot of questions. So our next speaker is going to talk about drug safety in pediatric emergency. His name is Jost Kaufmann, and he comes from Köln, Deutschland.
Yeah, hello altogether. Thank you for the opportunity to talk here. I'm from Cologne, as mentioned. I'm physician and anesthetist and emergency physician and intensive care physician. From my perception, the issue of drug safety in pediatric emergencies is still not in focus as much as it should be, and I'll give you arguments for my statement. Next slides. Oh, I do it myself, sorry. In a large pediatric emergency department in a large hospital in the US, there was a 7 month period where the people doing the pediatric prescriptions were asked to report tenfold dosing errors. This institution already had a few measures to optimize the prescriptions, like a computer system for prescribing. And they reported within this 7 months period 20 prescriptions within tenfold dosing error. This is one of 22,000 prescriptions. And then, very interesting, in the same department there was a period of 12 days when an experienced pharmacologist observed the prescriptions, and he detected 1 in 766 prescriptions a tenfold error. So a tenfold error occurs much more often, so 30 times more frequent than spontaneously reported. This is for 2 reasons. If you don't realize your error, you can't report it, and if you realize, you can decide to report it or not. And the conclusion of the authors was that it's much more regular than imagine the tenfold dosing errors, and the most important reasons for that is that you have different ampoule sizes and concentrations, but the most important reason is you cannot develop any familiarity with the dosage in pediatrics. On one of my worst days on pediatric intensive care use, we resuscitated a 800-gram extreme early born, and the same day, same ward, a 80-kilogram 15-year-old boy. So we have a dose range of 100. If you imagine a 40-kilo patient, adult patient, 100 would mean 4,000 kilograms. So obviously the range of weights is much different. And the next thing is the first drug dosing error I observed as a student working on an intensive care ward. An adult patient received 17 ampoules of pancuronium. So the one who was giving this drug really had a big chance to realize that there was something not normal. He opened 17 ampoules, draw 17 times it into a syringe, but still this patient received that error. In pediatrics, the same amount of dose, the tenfold error, is within 1 ampoule. So you don't have the same chance to realize that there is an error occurring. What does it mean? If you give adrenaline for resuscitation or epinephrine for resuscitation in pediatric patients, there was a trial published in New England Journal on equal calendar days. They gave, as recommended by the guidelines, 10 microgram per kilogram, and on unequal days they increased the rate to 100 micrograms per kilogram for the second or the third dose. And this trial was interrupted because no patient survived. So 100 micrograms per kilogram excludes survival by resuscitation of children, and this is the tenfold error with 1000% of the recommended dose. In the same hospital I mentioned before, the staff of the pediatric emergency department, so the specialized staff, was asked to do some simulated resuscitation scenarios, and they had 1 tenfold error each, 32 prescriptions, so 3.2% of the prescriptions was a tenfold error. In pre-hospital emergency care, the situation is even worse. There are just 2 trials ever published who focused on severe drug dosing errors to detect those in pre-hospital emergency care. The one I initiated in Cologne and the other one was in the US. We found an average adrenaline overdose in real life, preclinically, in Cologne of 880% of the recommended dose. This was the average overdose. And in the US, quite similar number with 808% of the recommended dose. So we kill children on an everyday basis worldwide. One of the cases was an 8-month-old child, ventilation which was found by the parents in the bed, not responsive, and ventilation was successful. This is the most important step for resuscitation in an infant. Pulses were palpable. We had an IO excess, but the drug dose was 250 milligrams per kilogram. So this is a 2.5-fold, 10-fold error, and this is not, the child did not survive by this. This is not a blaming of the physician who did that, but it really shows that we need to address this. We invented the first guideline, the German guideline, formal guideline ever published internationally. And one important step is to get the data of pediatric pharmacology. We have in Europe several databases that are freely accessible in the internet. I have shown here examples from Germany, Netherlands, Austria and Norway. And everybody should have access to the special needs for pediatric pharmacology. If you can access one of those, or a very good source is the British National Formulary for Children. Unfortunately, it's not available as an app, at least if you not work in the UK and for the NHS, but the printed version, I really recommend it. It's really a good reference for this. Most important things I want to focus in the rest of my lecture is what I call the psychosocial competence. The vigilance, my favorite story for the vigilance is on neonatal intensive care unit. There was a time when a pharmacologist checked the prescriptions without the staff knowing that, and then the pharmacologist announced that he will from now on check the prescriptions. Nothing else happens. There was nothing intervention, but the quality of the prescriptions enhanced severely, and the drug dosing error decreased. So the vigilance, and I think what we do here now, talking about it and getting aware about the importance, is one point that can increase the vigilance. So I hope all you listening have licked poison for this issue. We can reduce errors by that. The next very important thing is that we have to accept each and everybody has to accept for his own fallibility, and this is an example for missing this. This is published. The original text is published in a peer-reviewed German journal, and about this issue, a really known professor said the following things: an always available tool is my own brain. As far as this, when I reached the pediatric emergency, all right, I can check this, it's correct. Then he said its storage capacity can be expanded throughout life. Once stored information can be retrieved immediately at any time. I deeply admire this colleague for this, because with me it's very different. I learned the coagulation cascade like 50 times and forgot it reliably 2 days later again. But anyway, his potency is high. The next thing he said is the introduction of measuring tapes and rulers that does not make any decisive contribution to a reduction in errors. This is at least a failure of him. The pediatric emergency ruler, you can lay it on the child, and on the head end you can get the normal body weight, which is the best weight to drug dosing, and you can read the exact dose without any calculation. We did 2 trials with this, and this device is the first device ever worldwide where it has been proven that you can avoid severe drug dosing errors. You remember the number I said before, this 808% without intervention. With the pediatric emergency ruler, we had an average dose of epinephrine for resuscitation of 104%, so really as precise as possible. But also a simple table could help. This is a table where emergency physicians sit in a room with no time limit, no stress, no emergency case, and they were asked to give the dosage of epinephrine, child weighing 15 kilograms, dose of 10 micrograms, and they should give the number with a solution of 100 microgram per kilogram. Either they had no aid or they had access to this table. This table offers the calculated number ready to read. What happened with the unaided group, no table, they made 6% tenfold errors. So 6% of the children would have died. With the table, just 0.7, so 9 out of 10 cases where the child would have died would be avoided by the blink of a simple table. There's no other measurement in emergency care where you can save 9 out of 10 lives with all the efforts. So the focus must be more there. But when I read this the second time, I saw there's still errors occurred, and I've been interested in this question, and then I repeated quite the same study, but additionally asked the people participating who they are, and then we saw really astonishing results. We had the medical students, we had nurses, all from pediatric anesthesia or intensive care, we had trainees, physicians and consultants, and you see the light bars are the unaided errors. You see the medical students do most errors. 20% deviation is not a problem, but an academical grade, and 300% is a severe drug dosing error, and 1000% is the tenfold error, which excludes survival. The medical students do most errors. The nurses do less without aid, as well as the trainees, and the consultants even better. When they had been offered the table, the medical students did not do any error at all. You don't see any dark bar, no error at all. The nurses increased or decreased their error rates to a fifth or something. The trainees decreased it to a third, and the consultants, 2 of them killed the child by the tenfold error and repeated it, although the life-saving number was in front of their nose. It was very difficult to publish, and this is another example for the fallibility of the editor-in-chief of a renowned, highly ranked scientific international journal. He told me in the official communication why he did not accept the paper. It is unlikely that an experienced physician would make an order of magnitude error, therefore unlikely that any cognitive tool would assist in preventing that. It's an original citate. So the acceptance of fallibility is really an important issue, and there's a lot of evidence that seniority and hierarchy can decrease the acceptance of fallibility. The last thing is the communication. In every prescription we should make a full communication. Definitely with those drugs who are dangerous. Epinephrine is a dangerous drug if you give the amount is too high or you do a tenfold error. So everybody in the room, in the scene, should calculate, repeat your calculation. It's like 3 kilograms, child 30 micrograms, total dose, so 0.3 by the solution of 100. Fully announce that, everybody listen to it, repeats it, and then gives the drug, not before. My best example for this closed loop communication, how potent this is a real case of a 17-year-old Dutch lady on a Spanish bridge. She wanted to make bungee jumping. The instructor said no jump. She received now jump. And she jumped to death because the rope was not fixed. If she would have asked, should I jump, she would have survived. If we would ask before every application of epinephrine if this is the right dose, we would have saved a lot of lives. So my summary is, to err is human. Even experienced clinicians and high in hierarchy clinicians make errors. We should pre-sort our working space for sound-alike and look-alike things. A culture of error reporting is crucial. The awareness of everybody's own fallibility is essential. We should make rules, but these rules should be adapted to the situation, and the mandatory interim step before every medication, from my perception, is a very essential step. Thank you.
Thank you very much, Jost, for bringing up this topic and raising awareness. Now, our next speaker is going to talk about decision rules for imaging in pediatric trauma, and his name is Franz Babl from Melbourne, Australia. Welcome.
Thank you. Is it better to have the overheads on or not? What do you think? Okay, here you go. Thank you. So my name is Franz Babl. I am mainly a clinical researcher at the Royal Children's Hospital in Melbourne in Australia. And one of the areas that we are interested in is imaging rules. Much of the work that I'm going to present will refer to two research networks. One is the Pediatric Research in Emergency Departments International Collaborative, or PREDICT. And you see the logo on below. And I will also refer to the US network, the PCAR network. PCAR stands for Pediatric Emergency Research Care Applied Research Network. As you will be aware, if you're looking after children who have undergone trauma of any kind, there are many questions that are not highly evidence-based. But the elephant in the room for emergency clinicians is often whether patients should be imaged or not. And the three areas I want to focus on are neck injuries, head injuries, and abdominal trauma. And the reason why this is particularly interesting is because there's new evidence in all these three areas. And I'm going to talk about this a bit. Just to set the stage, there are clinical decision rules, which is what I'm going to talk about, and they provide specific guidance about one question. For example, should you image a patient or should you not image a patient? And then there are clinical guidelines, and the clinical guidelines, they place the decision rules into a context. But they also address multiple facets of diagnosis and management, in particular in areas where there is little evidence. And the guidance is based on best judgment and consensus. Why is this particularly important in trauma imaging? Because there is a big gap between the imaging rate that you will order in an emergency setting and the abnormal imaging rate. And that's true in multiple conditions. Also, the more severe end of trauma is actually a relatively infrequent event. I work at a major pediatric trauma center, so even in our setting, positive traumas on imaging is actually reasonably rare. And then there's also a high level of variation in care, which has been shown in multiple settings. This is an example. You can see three groups of hospitals here. These are Australian data, but you would probably find the same elsewhere. You have tertiary hospitals, suburban hospitals, and regional rural hospitals. And we looked at the CT imaging rate, and we severity adjusted that by the severity of injury, by GCS, etc. And as you can see, there is a huge difference between the low imaging hospitals and the high imaging hospitals, regardless of whether they were tertiary hospitals or not. Why bother particularly in trauma imaging? Well, because of radiation, because you may require sedation in children, and because of the limited resources that you're working with. If you image a lot of patients, they may all back up. You might not have radiology available, and there is patient discomfort and adverse events if you put a patient, immobilize a patient for hours. Why worry more in children about imaging? Children are smaller, children are growing, and they're more radiosensitive, and children have longer lifespans. So the first condition I'm going to talk about is cervical spine imaging. Again, there's new evidence in this space. Why are children and adults different? Children have big heads, they have underdeveloped neck muscles, and they have relative ligamentous laxity. And then they have ossification centers which make the scans look very different. So this is at the level of C2. On the left side, you have a normal 12-month-old. And on the right side, you have a normal 12-year-old at C2. So that looks very much like an adult image. What that translates into is that there is a difference in where injuries occur. So it's higher up, C1, C2, C3 in children, and it's further down in adults. And they also have more likely ligamentous injury or soft tissue injury rather than bony injuries. And in children, you also come more across kids who have underlying conditions, such as a Down syndrome, such as metabolic or genetic diseases, and other conditions. In the PREDICT network, we recently undertook a Cochrane review on triage tools for detecting cervical spine injury in pediatric trauma patients. And we found that there are 7 clinical decision rules. And the standout ones are Nexus, the Canadian C-spine rule, and the PECON criteria. So this was done before the latest paper that I'm going to talk about. And the bottom line of that, that Cochrane review was that we really need large studies to evaluate the accuracy of the clinical decision rules in children, and ideally conduct a direct comparison with each other across the rules. So the 3 possible existing rules are the Canadian C-spine rule, a large number of patients published in prestigious journals, Nexus, 34,000 patients, and then the PECON program. I will talk about that in a minute. When you look at Nexus, it basically identifies predictor variables, and if they are positive, then imaging is indicated. If they're negative, no imaging is indicated. The Canadian C-spine rule works based on high-risk criteria, low-risk criteria, and then imaging is either indicated or no imaging is indicated. The problem from a pediatric perspective is that the Canadian C-spine rule did not include any children in the derivation. The Nexus rule did include children, but there were only 4 injuries in children under 9 years of age. So what's the new evidence in this space? Well, it's from the PECON network. As I mentioned, this is the US research network. They undertook a huge effort. They looked at 20,000 children with possible cervical spine injuries. They were assessed for cervical spine injury. And as you can see, the rate is about between 1.5 and 2.5% of actual cervical spine injury. And different from the Nexus and the Canadian C-spine rule, if you look at the top line, you can see that 50% of patients were between 0 and 8 years of age. That's the critical difference. Most injuries were after motor vehicle crashes and falls. And what they identified is there are certain high-risk markers. Glasgow Coma Scale 3 to 8, abnormal airway breathing or circulation, focal neurological deficit, or any of the above. And if you look at the risk ratios in the column that's underlined, you can see that these were very high-risk conditions that made it more likely that there was a cervical spine injury. They then used a beautiful big computer program and identified further risk factors. And they included self-reported neck pain, altered mental status with a GCS of 9 to 14, substantial torso injury, substantial head injury, and neck tenderness on exam. And when you put this all together into an algorithm, as published in The Lancet, if you had a high risk factor, then the risk of cervical spine injury was 12%. And their recommendation was, because of that high risk, to consider a CT scan. The other risk factors, they would lead to a risk of cervical spine injury of about 3%. And their suggestion was to consider a plain X-ray at that point. And if there were no risk factors, the risk of cervical spine injury was 0.2%, and these patients could be considered for clinical clearance. Now, the sensitivity, which in my mind is the key marker here of the derivation cohort and the validation cohort, about 10,000 patients each, was about 93% in both cohorts, 93 to 94%. So it's very good, not perfect, but very good as a clinical decision rule. So there now is a high quality PECON rule available, but it does require external validation and comparison with adult-focused rules. And adult-focused rules are used in a lot of emergency departments across the world. That's where new evidence comes in. The SONIC study in Australia, it included sites from Australia, New Zealand, and Singapore. It enrolled 13,000 patients, and it is comparing the PECON, Nexus, and the Canadian C-spine rule. And that will be presented first time tomorrow at ICEM. And the first author is somewhere here. But I'm going to suggest that you come to that tomorrow. I cannot present these results because I don't want to steal the thunder from the presentation tomorrow, okay? Moving on to the next elephant in the room, mild to moderate head injury. Again, there is new evidence in this space. 3 big clinical decision rules amongst 20 other rules. The Chalice rule from the UK, the Catch rule from Canada, and the Pecan rule from the US. Pecan rule included 42,000 patients. And the key here is that they didn't want to just identify a bleed in the head. What they wanted to do was they wanted to identify a bleed or an abnormality on a CT scan, but also combine that with the requirement that it had to lead to clinical consequences, such as death, neurosurgery, intubation for more than 24 hours, or hospital admission for 2 nights or more. This is the rule for children less than 2 years, and then a separate rule for children greater than 2 years. And what it boils down to is, if all of these questions that they're asking, did the patient have altered mental status? Was there a occipital, parietal, or temporal scalp hematoma? Was there loss of consciousness? Was there a high-risk mechanism of injury? Was there palpable or unclear skull fracture? Was the patient acting normally or abnormally? If all of these questions were negative, then they had a very low risk of clinically important traumatic brain injury and didn't require a CT scan. The questions are similar in children greater than 2 years, but they changed a couple factors to history of vomiting and severe headache as key predictor variables. What does this translate into? You remember the algorithm from before, so a similar algorithm. So if they had GCS of 14 or other signs of altered mental status or signs of basilar skull fracture, their risk of clinically important traumatic brain injury was 4%. If they had some of the other factors, their risk was about 1%. And if they had none of these risk factors, the risk of clinically important traumatic brain injury was less than 0.05%. Their recommendation based on that was that the high-risk patients should have a CT scan. The low-risk patients did not require a CT scan, and the medium-risk patients should either be observed or should have a CT based on some other clinical factors, including multiple versus isolated findings, worsening symptoms, etc. Now, the question was still, and this is kind of similar to the SONIC study I presented before, how do these rules compare? Because in our setting, we were not fixed on a US rule or the Canadian rule or the British rule. So we compared this in 20,000 children in Australia and New Zealand. And what we found is that the Pecan rules were much more sensitive, or were more sensitive than Catch or Chalice, and missed very few patients. So in many countries, many systems, many hospitals, the Pecan rules have now been incorporated into clinical care. This is our national algorithm that we're using, and you can see the website there where you would find that. The new evidence here is that the Pecan group undertook a validation study with a new data set, 20,000 children with minor head trauma, and they found that the sensitivity is between 99 and 100%. So these are just very solid rules. So the Pecan rules for head injuries are highly accurate. They lead to a safe reduction in CT scans, and they have undergone internal and external validation and have been incorporated into many clinical practice guidelines. I have 3-4 more slides. Is that okay? Thanks. Finally, abdominal trauma. There is also new evidence in this space. So again, the Pecan, as you can see, I'm a big fan of the Pecan group and their work. The Pecan group developed a clinical decision rule in 12,000 patients with a possible abdominal trauma. They wanted to identify intra-abdominal injury, but again, their plan was not to just find blood somewhere. or an injury that had no consequence. They wanted to find intra-abdominal injury undergoing acute intervention, so laparotomy, embolization, blood transfusion, IV fluids for more than 2 nights, or death. And what they found as the markers was, if you look at that list, abdominal pain, vomiting, GCS of less than 14, absent or decreased breath sounds, evidence of thoracic wall trauma, evidence of abdominal wall trauma, abdominal tenderness. If all of these were negative, the patient had a very low risk, a 0.1% risk of intra-abdominal injury requiring intervention, and therefore didn't require imaging. The other factors were stratified. They had different risk factors, as you can see, between 1% and 5%. The new evidence in this space is that, again, PCORN undertook a validation study, 7,500 patients with abdominal trauma, and these were mainly motor vehicle collisions, and about 40% of them were admitted to hospital. And the sensitivity of this rule was 100%. So it's a highly sensitive rule. So the bottom line here is, to sum this up, for neck injuries, there's a new PCORN rule. It's pending comparison with adult-focused rules. And again, I'm going to ask you to come tomorrow to see the results. For head injury, there's an established PCORN rule, and same for abdominal trauma. If you want to know more about these rules and how they fit together, there was a paper that we published in 2024 on comparing these rules. And I'm happy to answer any questions at the discussion point. Thank you.
Thank you very much, Franz. I haven't seen our last... okay, so great. So then our last talk is about ketamine in critical illness, friend of foe in intubation. We have Sebastian Osorio, Medellin, Colombia.
Medellin, Colombia, yeah.
Welcome.
Thank you very much. Hi to everyone. My name is Sebastian Osorio, and I'm an emergency medicine specialist from Colombia, and also an adjunct professor from the University of Antioquia in Colombia. I apologize for any kind of English mistake in my pronunciation. As a Latino, it's really difficult to keep that pronunciation as well. So I have no conflicts of interest to declare, and in the next few minutes we have to tell a history about the ketamine, the pathophysiology of ketamine in critical care patients, the translational gap, trying to translate the in vitro studies into critical care patients when using ketamine, and some kind of insights into the recent evidence of ketamine in critical care intubation. So first of all, let's talk about the history of ketamine. Ketamine was born as a race for trying to find the perfect induction agent for anesthesia, and an anesthetic agent that provides analgesia and amnesia, while preserving the airway reflexes and cardiovascular stability. And when Dominico's and it all found this agent in the late 50s and in the early 60s, the ketamine became very popular in military settings, including the Vietnam War. But after that, in the 80s and 90s, there started to appear a lot of articles, a lot of studies in early animal and in vitro studies that found that ketamine could have myocardial depressing effects, a reduced contractility in isolated heart and human atria, and it depends on these functions on endogenous catecholamines. And from this center, there starts to appear some observational and RCTs in critical care patients where there's an emerging signal of harm in severe shock patients when you use ketamine. As a pathophysiology, we all know that ketamine, beyond the MNA receptor effect, has an indirect systematic stimulation or an indirect sympathetic stimulation through an inhibition of the norepinephrine reuptake and the inhibition of oral monoamine uptake like epinephrine and dopamine. But the other side of the history is that ketamine also have a direct myocardial depression function because of the inhibition of the L-type calcium channels, the blockade of voltage-gated sodium channels, and the interaction with another channel that could cause a decrease in chronotrophy, conduction, and contractility. And on this, all of these effects can cause myocardial depression in vitro or in vivo cardiac studies. But how to apply all of this info in the critical ill patients? There is actually a translational gap because all of this info about ketamine or ketamine as an agent of induction come from studies where stable patient, in fact, the famous dose of 2 milligrams per kilo is based in a study of outpatient surgery of gynecology or obstetrics and not a critical care patients study. All of these studies are controlled environments or are drugs in isolation humanitarian, or they evaluate surrogate studies, but in critical care patients we don't have that. We have shock patients, we have myocardial dysfunction, we have acidosis, hypoxemia, co-intervention like inotropes, vasopressor, fluids, etc. So how to translate all of that info into the real cases? So what about the evidence? If you do a quick search in the literature, you can find around this kind of evidence overview. You have at least 5 randomized trials, you have at least 7 prospective studies. The most famous of them is the NEAR registry, the National Emergency Airway Registry from the United States, and at least 30 retrospective studies for a total of 42 studies with at least 40,000 patients. And there are some kind of conclusions. One of them is that there is high-risk patient that could have an unweighted high-potential response when using ketamine, but there is a high heterogeneity of definition. There is a lot of studies that try to measure the same event, that is cardiovascular collapse, with many different definitions. A drop of 30% of the systemic blood pressure, a drop of just I don't know, 50 milligrams mercury of the blood pressure, a drop of the median pressure or around 50%, or a drop of the systolic blood pressure below 65 millimeters of mercury. And this is a summary of the outcomes that most of the study tried to evaluate. About the mortality, most of the study found that they're neutral between ketamine or induction agent like etomidate. But most of them talks about a possible increase in the hemodynamic stability. There's inconsistent findings about the vasopressor requirements, of the new use of vasopressor, and this is uncertain if there is a dose response or what is the ideal dose for ketamine, because as I told you, most of the doses described for ketamine are divided for a stable patient and not critical care patients. So we're going to discuss a little bit about the RCT comparing ketamine versus etomidate, because the big discussion about the best induction agent for a critical care patient is just trying to evaluate ketamine versus etomidate in the last 20 years. So we have at least 5 good, well-done RCTs for ketamine versus etomidate. The first of all is the 2009 Gabriel et al. Compare ketamine and etomidate, but discussion on this trial was about one mortality and the adrenal suppression, adrenal insufficiency induced by etomidate. But 13 years later, we start with the era of more RCT compare ketamine and etomidate. The EVK is famous because it's the first trial where they found an association with ketamine and cardiovascular collapse. And some of the other trials just trying to find some association between etomidate and the lung or organ dysfunction of the SOFA score between ketamine and etomidate, until the last year when the RSI trial was published in the New England Journal of Medicine. So we have a total of 5 RCTs with more than 4,000 patients, but the most important evidence came the last year with the RSI trial, so we're going to discuss the trial. The RCT trial published in the New England Journal of Medicine last year was conducted in the USA and includes 14 emergency department and intensive care units with at least 2,000 critical ill adults. It's important to clarify that they did not include trauma or hemorrhagic trauma patients. And this patient was randomized to ketamine versus etomidate, and they measured the outcomes which found was the mortality at 28 days and the cardiac collapse. Here are the baseline characteristics from this trial. you can see that there's a lot of people. And it's important to say here that all of the patients have sepsis or septic shock. That is one of the concerns with the use of the etomidate. At least 22% of them has a pressure prior to intubation. The PaC2 was high between both of the groups, and all of them was intubated in the emergency department, and almost all of them was intubated in the intensive care unit. So this is the findings. The primary outcome, that is in-hospital mortality by day 28, was very similar between both of the groups, with no absolute difference or relative difference between both. And the secondary outcome, that was cardiovascular collapse, there was a higher risk of cardiovascular collapse with a ketamine use, with a number needed to treat of almost 20. And beyond this result, I think that one of the biggest finding is that cardiovascular collapse is very common regardless in the induction agent that you use. Even with ketamine or etomidate, at least 1 on 5 or 1 on 6 of your patient will have a cardiovascular collapse. When you try to analyze these findings, you have to remember that cardiovascular collapse is a composite outcomes that is derived from cardio arrest, systolic blood pressure below 65, and the use of new vessel pressure or the increase in the use of vessel pressure after the intubation. And you can see that the difference is almost explained by the use of new vessel pressure and not because a systolic blood pressure below 65 or a new cardiac arrest between both of the drugs. So try to analyze these findings by subgroups at risk. We can find that in septic shock, look at that difference. There is an absolute risk difference or around 9% or 10%, an additional event for every 10 patients. So the number to treat decreased from 20 to 10 in septic shock patients. And in the patient who are most illness, like PaC over 20, you can see the same thing, that is that absolutely risk difference of almost 11% and an additional event every 9%. So the number needed to treat from 20 can be decreased to just 10 or 9 when it includes or when you evaluate this in septic shock or a PaC over 20. So this model can explain the effect of clinical use of ketamine in critical care patients. We have some variables that can have a direct association with a positive clinical effect, like the sympathetic reserve and the cardiovascular reserve. You have a lot of these, you can probably have a low or a direct myocardial dysfunction with ketamine. And there is association obviously inversely proportional with the physiological stress of intubation and the shock severity, as you can see from the RCI trial findings. So this is a framework that what we can do trying to deal with this risk of cardiovascular collapse with ketamine use in critical care patients. When you take the decision to intubate, most of the times intubate is just let us a few minutes to think or to assess or to trying to get prepared for where it's coming from. So when you take that decision to intubate, just try to assess a pre-intubation physiological reserve, do a clinical exam, evaluate the fluid status focus or clinical examination, try to get the sympathetic reserve of the patients, the cardiovascular reserve, how is the cardiac function or the precardiac function, and how is the respiratory reserve of this patient that you're trying to intubate. After that, just this is for all of the patients, regardless of the induction agent. Do a pre-induction hemodynamic optimization. Give fluid resuscitation if there is a clinical context of hypovolemia with a close monitoring of the response. Get prepared for the use or the new use or increases doses of vasopressor after the intubation, and try to anticipate in case of the forced to act intubations. After that, just integrate this in a risk-benefit framework, and there's a favorite patient just use ketamine or etomidate. But it is unfavorable, just try to use etomidate if available. But don't forget that even with etomidate, you had a probability of 17% to get a cardiovascular collapse. And this is very important because in many settings and in many countries, even low and middle income countries, etomidate is now massively available. And even in some high-income countries, etomidate is not available. So if you had to use ketamine, be careful with the high probability of cardiac collapse in this type of patients, and be careful with the use of opioids, because with ketamine you can provide analgesia, and you don't have to use opioid for analgesia. You're using ketamine, and if you're using opioids, trying to avoid the sympathetic activity of with trying to manipulate the airways, you do need to induce this sympathetic activity, so don't try to avoid it with opioids. After that, just assess dynamically after the intubation, and this brings to us the future consideration about these themes or this topic. You need to do more precision medicine. What about this unexplored scenario or unexplored area like trauma or any other kind of non-septic shock like cardiogenic shock or neurogenic shock? The discussion about the frequency of cardiac collapse should move to forward to any kind of preventing collapse or preventing intervention to prevent collapse, like fluids, like vasopressor, like any kind of this kind of intervention. And beyond blood pressure, we had to clarify what are outcomes matters and how to define them, because there is a high heterogeneity of the definitions of cardiac collapse or hypotension post-intubation. And there's a real concern about the dosage, about what is the best dosage according to the patient, because, for example, I think that a patient with encephalopathy doesn't need a dose like 2 milligrams per kilo, and just 1 or even lower than 1 milligram per kilo. So as a take-home message, ketamine is not universally hemodynamically neutral as we thought. And more than the induction agents, the patient physiology matters, not just the drugs itself. The recent evidence finally challenged traditional assumptions about the ketamine, and from which induction agents we have to move forward to which is the best for this kind of patient specifically. Thank you very much.
Thank you very much, Sebastian. Now, let's see, where are the instructors? The presenters. So if anybody has a question, I'm going to throw this. Okay, so try to catch.
Thank you.
Franz, is he still here? Franz is there, he can hear you. So for whom is the question?
For Dr. David Ng, if he's still here.
David's here.
Oh, perfect. Nice.
Sorry, I missed the question.
No, all good, all good. Hello. Thanks for the wonderful talks from everybody. That was a fantastic session. I really appreciate it. My name's Will. I'm a medical student from Canada.
Okay.
And very nice to meet you.
Nice to meet you. I'm just going to go with naked ear here.
Yeah,
I think it works better for me.
Sounds good. I have a background in stroke research, so I've drank the thrombolytic Kool-Aid for sure. So I'll preface that before I ask my question. But, I think we can draw some kind of parallels between central retinal artery occlusion and minor disabling stroke. Not all parallels, but some. And, the data from that field, unfortunately, wasn't the greatest in the thrombolytic trials with Tempo 2 and some of the meta-analyses, and they saw, a kind of 2% risk of serious intracranial hemorrhage and death. And then, in the trials that we do have for CRAO, it is also doesn't look, unfortunately, terribly promising, especially this one from January. It was under 4.5 hours. They still saw, a death and symptomatic intracranial hemorrhage. So I'm curious if you think we really should be considering it at all right now, or if it's better left for trials and, getting the better data before we even as kind of an emergency physician group really consider it. Because it just seems like the risk is too high and too unknown at this time.
Yeah, and I think that's why we are where we are. It's not a gold standard, it's not an algorithm. Even where I work at a stroke center. We haven't formed an algorithm for this. But I feel like there's still such thing as I don't know, if I had a monocular patient who's already blind in one eye, and this is their last eye, and I think it's CRAO, and I think I can get an ophthalmologist to come down see them, and our stroke neurologists, and our stroke teams are admitting them, and they are considering, and our neuro-ophthalmologist wants to see these patients and wants to consider TPA or sorry, IV, and even intraarterial. So we have the infrastructure loosely for it. So since it exists for me, who am I to say no? I mean, I can't because of the trials, but I agree. The trials so far don't look promising. But the trials, as you mentioned, they aren't definitive, right? They're very small. It took them 5 years to recruit 70 patients for the one in France. Something similar, 5 years for another 78 patients out of the Norway trial that was reported this year that you're mentioning. And so I think revision, which will be up to 400 patients. So that's going to be, it's going to be like 4 times the size of what we've done so far. I think that'll be definitive. So right now I agree, not a gold standard, is an option, but loaded with those sort of reservations that you've mentioned.
Thank you.
Great.
Yeah, thank you.
Hey, I'm not going to throw it. I'm going to give it like this.
Thank you so much. Thank you. Hi, I'm Jo. I'm actually an emergency physician, currently based in Melbourne, Victoria. So I work in 2 parts of Victoria. One is Melbourne inner city, where we have hyperbaric. I want to ask, number one, the utility of hyperbaric in CRAO, and the second thing is, because I work in a regional part of Australia as well, where we do not have ophthalmologists, and the nearest ophthalmologist that we can actually send to is about 2 hours away. But we do have fundus photography in our ED that we can actually send the pictures to the ophthalmologist, but we do not have OCT. How pertinent is OCT to actually make the diagnosis prior to actually moving forward to the neurology part of CRAO management?
These are great questions, and they're really context specific. I'll answer the first one. So you brought up hyperbaric. I didn't get a chance to touch on hyperbaric. So there's some weak evidence about how if you have a patient on hyperbarics, that there is collateral circulation that still runs, and then that oxygen diffuse into that retinal layer that's starving, and then that can be helpful. I think, I'm not an expert on the hyperbarics bit, but my understanding of that literature is that we can consider it, if you have it, as a bridging therapy. So you're thinking about doing something maybe like lysis or not, so you're going to bridge them until they can get a chance to get those things, maybe buy them some time. I don't think that there's any convincing evidence that I've seen where, okay, we want to put them in hyperbaric so that they can actually get their vision back. That part I'm still not too clear on. And your second question, I think there's a good point. You have the camera, and how important is OCT? I don't know the literature. I've talked to our own neuro-ophthalmologist, or the experts in this area. He didn't have the number, but he did report to me, look, you guys send these patients to my clinic, and the ophthalmology resident did not see a pale retina, but by the time they get to my clinic, they do. And the idea is that OCT should be able to catch those. Exactly what the number is, they're not sure. But if this therapy in the hyperacute phase becomes legitimate, then I feel like that's an area of research that needs to be pursued, because the OCT camera could make the difference. However, they are really expensive. I think they're $75,000 US for a machine. I think the only way it's going to work is you're ringing up the ophthalmologist and waking them up all the time for it, that they pay for it, because they don't want to have to come in anymore. But I think that's where we're at with that. Yeah. You're welcome.
Okay, great. So we have another. Your question is for whom?
It's for Helio. Penna.
Helio. Helio.
Is it gone?
I can't see him.
You can't see him.
Unfortunately.
Okay.
I'm sorry for that. Raise your hand if you have a question. For whom is a question?
Regarding the C-spine.
Yeah. Franz.
Thank you.
Hi, thank you for your talk. My question is about the PCARN. What do you do when the recommendation is consider plain X-ray with the PCARN? Because we don't get to do plain X-rays for C-spine injury if the recommendation is consider plain X-ray with a stated rest of 2.8%. Do you do plain X-rays or you move for CT?
Well, the current clinical decision rule or the interpretation by the PCON group in terms of the algorithm essentially sorts patients into higher risk patients for CT scan, medium risk patients for plain X-ray, and very low risk patients who can just have clinical clearance. When you ask, or when you look at what people are actually doing, in terms of do they use X-rays, CT scans, there are no data yet that would show how the PCON rules, because they are really brand new, how they have translated into practice. I think that's what you're asking, right? We don't know if people actually, if they have a tradition for doing CT scans, that they do CT scans. I can tell you from our data that will be presented tomorrow is that there is variation between hospitals, that there will be hospitals that have a higher imaging rate for CT scan and lower rate for X-ray and vice versa. In fact, there are hospitals where, for some reason, the MRI has migrated into the center of imaging. So I think bottom line is we don't know yet what the impact is of the PCON rules.
Thank you.
Thanks.
For whom?
Ophthalmology.
Okay. For ophthalmology.
Good morning. Thank you for an excellent presentation. My name is Michael from Manchester, UK. I appreciate that thrombolysis is still controversial. There's pros and cons. But if the decision is made to give it, who makes the final decision? Ophthalmology or stroke physician?
It will be stroke or you. Or where I would be, it would be either stroke or myself.
For whom is the question?
Ophthalmology again. Any role for the ocular massage or CRAO?
No.
Okay.
Okay. That was quick. Okay. Other questions? Then thank you very much for coming. Thank you for giving these great talks.
Thank you very much, everybody.